When we start to look at just general imaging with systemic disease, we see some of the most unique images in cardiology, and they're not related necessarily to the heart. We have depressed myocardial function, inflammation. Heart valve disease can be associated with problems, intracardiac masses, myocardial deposition diseases, pericardial disease, inflammatory diseases such as vasculitis, and emboli. I'd just like to start very briefly with a case, a 34-year-old Asian male being breathless and developing ankle swelling. And all of us, I think, would have no hesitation in making the diagnosis. We can see here there is thickened pericardium, both visceral and parietal. There is abnormal motion of the septum. And when we look at the walls, we can see a furence exudate into the pericardial diffusion. I think we all can guess that this is acute, ongoing tuberculous pericarditis. We can use our imaging tools to look with the respiratory trace and an M mode at the ventricular interaction. We can look at the pressure in the IVC to show the obstruction. And we can see abnormal variation in mitral flow. And indeed, this was tuberculous and required the fluid removed. Now, constrictive pericarditis, chronic progressive, can be tuberculous, infective, post-radiation, autoimmune, post-trauma, especially car accidents with penetrating rib injuries, and renal disease. However, something that we don't recognize is up to 20% of constrictive physiology cases occur within the 4 to 6 weeks post-cardiac surgery. And this often is temporary. So post-cardiac surgery can give you restriction, restrictive physiology, infarction, connective tissue disease, and localized pericardial effusions. Now, this was an interesting lady admitted from outpatients following routine assessment post-AF ablation. She had weight loss and was easily tired. The transthoracic echo showed aortic regurgitation, which had previously been unrecognized. And these are our images: a dilated left ventricle, a curled up appearance of the aortic valve cusps, and a normal-sized aortic root. Her aortic regurgitation was totally disproportionate to her cusp morphology, and her left ventricle had acutely dilated with an end diastolic dimension of 61. She then was investigated further. She had a mild anemia, massively raised CRP, no evidence of vegetations, and she was culture negative, but was suspected of endocarditis, discharged home following 6 weeks of antibiotic therapy. She was readmitted 3 weeks later with worsening short of breath and pulmonary congestion, and she dropped her hemoglobin very significantly and now had a CRP of 250. The echo showed further left ventricular dilatation and now thickened and echo-bright leaflets of the mitral valve. This had appeared normal before. She had severe aortic regurgitation and severe mitral regurgitation, but again, no evidence on a second TOE of vegetations on the aortic valve. Nothing on the mitral valve either. Sterile endocarditis, possible connective tissue disease with cardiac involvement. Referred to the rheumatologist, probable vasculitis, and a positive PET scan. Her diagnosis was giant cell arteritis, which was presented as involving the heart valves. She was then treated for this with quick improvement of all inflammatory markers and put to observation as her aortic and mitral regurgitation diminished but weren't absent. There are a number of vasculitides that can involve the heart: Kawasaki's, giant cell arteritis, Takayasu, polyarteritis nodosa, Wegener's, and Churg-Strauss. And we have to keep these in mind when we see patients we suspect to have culture negative endocarditis. It's a fascinating case. A 21-year-old tennis coach, fit until 2 days ago. He presented acutely with central chest pain and dyspnea in bed at night, shocked. His ECG showed him to have acute inferior ST elevation myocardial infarction. And this is the echo I did in the emergency room. I think you would say this is a very abnormal echo. The one fascinating thing is here we have compression within the pericardium by a large, what seems to be a cyst with thrombus around it. But the keynote thing here is to look at the basal septum And you see the basal septum is scooped out here in a most unusual way, and he's abnormally hypertrophied. You then look at his flows, and you see that from the ascending aorta, in a precaudal study, he has mild aortic regurgitation, but he has flow out from his aortic root into the cavity we saw. When you then look at the flow in and out of that cavity, it is obstructed coronary artery flow. So he has right coronary artery connection to this lesion outside. Now we start to look at flow within the mass itself, and you will see that this mass has a central flow. You see spontaneous contrast, and the mass within the pericardium is compressing the pulmonary artery. The pulmonary artery flow is mildly stenotic. What is this? This young man had Kawasaki's disease in infancy, unrecognized. He had a first diagonal infarct of unknown age, and that explains the upper septal scalloping out due to his infarction. What had happened this time is an aneurysm of his right coronary artery had ruptured. This had given him an inferior infarct. He had a large intrapericardial clot and tamponade. He was then referred to the surgeons who operated on him. He had right coronary orifice occlusion, aneurysm resection, distal RCA mammary grafting, and he did very well. However, coronary angiography showed him to have significant residual lesions, and he's at very high risk of further infarction. Now, in terms of endocrine disorders, carcinoid, pheochromocytoma, paragangliomas, thyroid disorders, and secreting tumors all can present as echo images of involvement of the heart. This is a 53-year-old male patient with long-standing ischemic heart disease. He became severely and progressively breathless and had abdominal distension with gross lower limb edema. On his transthoracic echo, he had a very large mass. And the initial findings, you suspect this is a mass within the left atrium. But remember, 2D echo has depth to it, and this may be slightly out of plane as you see coming into plane. His proper echo image showed him to have a huge mass in the right atrium projecting through the tricuspid valve, and it had some cystic component to it. Anyway, I'll just go through and finish quite quickly. Remember as well, in systemic disease, you could have myocardial deposition diseases, amyloid, mucopolysaccharidosis, Anderson-Fabry, and mitochondrial disease. And Bart in his previous talk has dealt with hypertrophy quite well. But when you see an image like that, you have no doubt that the diagnosis is amyloid. In terms of hematology, we have problems with Behçet's, hypereosinophilia, lymphoma, polycythemia, and clotting disorders. This is a 40-year-old patient with an acute apparent myocardial infarction. Imaging showed him to have a large thrombus at the apex. Coronary angiography showed relatively normal coronary arteries, but slow coronary flow. His MRI showed a large organized thrombus in a previous apical infarct. When you go to the history, he had had multiple severe migraines as a child. In 1997, acute cerebellar syndrome, and again, 1997 to 2003, multiple migraines. 2003, a sagittal sinus thrombosis and unilateral papilledema. And 2003 to 8, he was in neurology follow-up. Basically, he had multiple clotting problems. And during his cardiac admission in 2009, he was shown to have congenital hypofibrogenemia. He persistently reduced fibrinogen. Anticoagulation in these cases doesn't work. And he was put for therapy with a novel therapy for fibrinogen concentrate administration to suppress indigenous gene. And he has remained relatively well on this therapy. Last case I want to show you is a 32-year-old male, pyrexia of unknown origin. He presented with breathlessness and a right lower lobe consolidation. He was given antibiotics for suspected pneumonia. He then developed a apparent pulmonary embolus, but no source of peripheral clot was found. We were then asked to do an echocardiogram, and within the right ventricle, you see that he has a number of clots adherent to his papillary muscles of the tricuspid valve, and we presume these had embolized off, and this caused his pulmonary embolus and his right lower lobe lesions. It was decided to do a surgical excision for histology. And indeed, this was effective and removed the masses. The masses showed blood clot, purulent exudate, and features of infected thrombus. His bone marrow was normal, and he had no malignancy. 7 weeks later, he was apyrexal and off antibiotics. For 2 years, he was followed up with a normal CRP. Then he had recurrent sagittal sinus thrombosis and cerebellar infarcts. The whole entity was explained by having Behçet's disease. Now, in terms of systemic diseases involving valve leaflets, secondary endocarditis, rheumatic fever, connective tissue disorders, paraproteinemias, drug therapy, and radiation therapy. 62-year-old male, admitted with pyrexia of unknown origin, weight loss and Raynaud's, multiple cardiac murmurs, possible endocarditis, but culture negative. And this is his image, a very thickened aortic valve, stenotic and severely regurgitant. But if you notice, there is also a mass lesion on the aortic valve. If you look at his other valves, his mitral valve is thickened and very abnormal. His tricuspid valve is grossly abnormal as well with thickening. And at the bottom right, you can see his pulmonary valve is very thickened. All 4 valves are abnormal with thickened leaflets and possible vegetations on the valve. These are his Doppler findings indicating stenosis and regurgitation of every single cardiac valve. I had never seen this before at all and wondered what it was. Investigations were very unhelpful. No evidence of autoimmune disease, bone marrow negative, blood culture negative. However, he then developed evidence of a profound paraproteinemia. His diagnosis was atypical lymphoma with deposits on all heart valves. He died from severe cardiac failure 3 months later. Now, I've finished this presentation at this point in time for the sake of time, but I've tried to remind you that so many systemic diseases will present uniquely with cardiac involvement, and this may be their first presentation. In general, they will all be culture negative and they will be progressive. We always, when we scan patients, must remember this. And I think showing such patients in a meeting like this serves to remind people that it is worth looking at rare cases and learning from them, because if you see them presented to you, you will remember in the future what they are or what to exclude. And I hope that brief look at systemic disease involving the heart has been of value. Thank you very much.